Well, good afternoon, morning, soon to be afternoon, but it's great to be with you. I have got off the airplane about 2 hours ago, and I left about 30 hours ago from China and through Hong Kong, and I look pretty good, don't I, actually? I checked into my room at 9:30 here and took a quick shower and got a little bit of food. And I tell you that only because when Christine and Neil called about 9 months ago, and invited me to be here with you, I said it's going to be tough to do because I've committed a year ago to be in China. And I said, but I'm going to be there, whatever it takes. And I say that with all sincerity and with all honesty, because to be in a room like this with 450 people who have come together with a simple, very simple mission that centers on quality is a great opportunity for me to share with you, first of all, my thanks, but also my encouragement to you to stay exactly where you are. I say that because of all the things that I do, and I do the private equity world, I start companies, I've had the opportunity to lead the most powerful legislative body in the free world. I'm a cardiac surgeon, I love it. I do surgery around the world. Put all of that together and connect all of those dots, I will say, and this is the only audience I can say it in, that there is where we are today in healthcare, in financing, access, delivery, all of the issues that we know, the challenges that are out there that are highlighted in this town in particular as we try to face them. There is no more important, significant, central organizing concept or principle than quality. The quality measurement, the difficulty we have in saying, we know what quality is instinctively, but putting the numbers around that quality, putting the measurements and the metrics, there is no more important issue today in this time of change. And I say that not knowing more than any of you in the room, but being able to connect a lot from the financial world, from the political world, from the healthcare delivery world, from the transplanting hearts world, to the science world, to the innovation. There's nothing more important. And I say that really is sort of my beginning statement and my final statement. And I'm going to pack here about 25 minutes just with some observations of where we are today. There's no more exciting time. I missed the panels this morning, and I don't know what the congressional staffers, what their feeling was. But based on the patient, on the individual, on the family, there is no more exciting time, challenging time, but exciting time today than the last 35 years that I've been sort of active, really active in the field of delivery and care. And I say it from the patient's perspective, not the policymaker, not the senator, not the surgeon and all that, from the patient's perspective. Why do I say that? Because the issues of affordability for the first time, the tools are out there because of where we are in 2015 that we weren't in 2014, or we weren't in 2003 when I and a bunch of others put prescription drugs in Medicare for the first time. And we had the pharmaceuticals and the sort of bidding back and forth and the changes that we put in there. We just didn't have the data. But today with parallel computing and supercomputing combined with the scientific data we have, with the information technology that's made available, not just by the apps and our iPhones and our iPads, but made possible today by big data, where you can have automation, like with electronic health records, where you can have connectivity where the doctor's office and the hospital and the rural health clinic and the community clinic can begin. We're early on, but they have the tools there to begin that connectivity, coupled with the real power of, from a physician standpoint and a nursing standpoint, where you have genomics and proteomics, and to make a decision in a few minutes or an hour even, you have thousands of bits of information coming in to make those decisions. But now we have not just the automation and the connectivity, but the decision support. Little red flags coming up on your computer if you prescribe erythromycin when somebody's on cyclosporin, and you don't know anything about the transplant world, but it will shut down somebody's kidneys, and a red flag comes up now. And it didn't 4 years ago or 5 years ago. And then the last component of the information technology revolution, which makes the measurement and the metrics and the analytics of quality possible, is the really exciting true informatics. With informatics meaning not electronic health records, but informatics meaning big data, data speaking to data, extending the human mind and the power of the human mind in this world of big data. So the information technology where we are today in 2015, with the empowerment of our Fitbits and our Jawbones and our devices just coming on board, this aggregation of data that comes down to what may be called precision medicine, as well as population health coming together, all center around quality, the patient, how well they do, what those outcomes are. There is going to always be a bell curve of some sort of curve of quality, but now we have the ability to measure, to analyze. And yes, it's young. And when I was in the Senate, 6 years ago and was doing nothing but healthcare, quality was out there and we were pushing for it, but now we have the tools. And we didn't have them, I say 3 years ago, we didn't have them 2 years ago. And that's why, one of the reasons I am so excited. Christine, it's great to see you again. I appreciate your tremendous leadership. Helen Darling, who I saw as well, again, very good friends who've been on the forefront in leading your organization, but more importantly, the real global community in terms of looking at and measuring quality. Let me do a couple of things. I'm a surgeon, so I keep things really simple. So when I think of quality, we're moving from fee-for-service to value-based, the sort of words that we play with all the time. But at the end of the day, we all go back home today or tomorrow, and we got to sort of think through how do we apply what we're doing to quality, true quality measurement, and then the analytics so that you can do comparisons so that you can incentivize people to improve. So I look, just so you'll know, I look at value, move to value-based. A ratio comes up in my mind immediately, and then the numerator is the outcomes and the results and the quality. And the denominator is a big dollar sign for me in terms of per dollar invested, and that's the value equation. This integral sort of integration, assimilation, amalgamation of value being quality and cost means, in my mind, if you focus on the quality itself and you improve the quality, the ratio by definition will get larger, and therefore you're affecting value. I want to give you 3 examples before I finish today on the way that many of people in the private sector approach this value equation in terms of quality, but the way it is tied to and linked to that cost, that per dollar invested. I'm not sure how much, and I've asked several of you just coming in the room how much you talked about the Affordable Care Act and Obamacare, where we are today. And that's not the purpose of today, but all of you pretty much know where we are. But there is a decision that's going to come by the Supreme Court in June that will greatly affect this whole movement of quality. Our movement of quality is one with all this change. Supreme Court, back several years ago said Medicaid, nope, you don't have to expand. We don't know exactly what they're going to say in June, but to have the quality measurements be the tracks, sort of be the well-defined tracks going forward, it doesn't matter very much what happens, because if you have the tracks there, you're going to be able to correct and self-correct. If the Supreme Court itself in this Burwell decision basically says, and it's not a matter of constitutionality, it's a matter of just several words in the statute, but basically rule with the plaintiffs, what's going to be important for us is to stick on quality, because 8 million people will be affected and it will require some legislative change. Has Obamacare been effective? We're 5 years into it. And if you go back and look at your notes from 5 years ago, and I did because I serve on the Kaiser Family Foundation, I serve on the Robert Wood Johnson Foundation, I serve on nonprofit foundations that really care about affordability, that really care fundamentally about access, that really care about quality. But my notes are very clear at the time, and the Affordable Care Act didn't have its fundamental intent improving quality. That's not the real purpose. There's a lot written in their demonstration projects and their pages written, but the real intent of the bill was to take out of about 47 million people uninsured at the time, 16 million people, put them in Medicaid, and 16 million people put them through exchanges. Personally, I like both of those. If somebody has a little bit of insurance and they come through the door, they get better care. And in my mind, as a physician who's taken care of thousands and thousands of patients, done thousands and thousands of big operations, if you have a little bit of insurance, on average, you're going to live longer. Gross generalization, but just so you'll know from my standpoint, it cares. Has Obamacare been successful in that regard? Because, and this is inside baseball and all of you know, the way it was passed, and it depends on what you're on the left or the right or Democrat or Republican, doesn't matter, but it was rushed through the congressional body in a way that it was dealt with like no other social issue. Not Medicare in the past, not Medicaid in the past, not Social Security in the past, not civil rights in the past. All of those went to committee. But this, because it may not have gotten through, a decision was made by the leadership at the time to push it through where it never went to committee. The House and the Senate could get together, work through the words, work through the intent, kind of shape the bill. It didn't go through that, and now we have a Supreme Court decision in June that won't totally dismantle the bill, but all of a sudden, if you start pulling 9 million people, their insurance away from them after you're given to them in a bill that is not popular today, does not have the majority support of the American people, it does not have majority support of the people they represent, the House of Representatives, nor the United States Senate. So if you start unraveling, and it unravels even more than it has, there's trouble. Not repeal, it's not going to be repealed, but it'll have to be patched. It'll have to be patched. Whenever you start patching something and you get away from the central organizing principles, it ends up being less efficient. So we have the Burwell decision that's going to be coming up. The arguments we heard last month. It'll probably be decided either probably one vote, one way or another. And the Burwell decision is based on, right now, federal exchanges and state exchanges right now are being funded. Those people, whoever, it didn't matter whether you went to a federal or state exchange, you're getting a subsidy if you meet the criteria. It is written that only state plans are to be given those subsidies, but most states didn't set up plans because it was too confusing, it was too hard. It was just easier to say, federal government, you do it or you start doing it. So most of these plans were set up, the exchanges, through the federal level, but it does say in there that it has to be a state exchange to be subsidized. So it'll come down, is it the intent? What was the intent when the bill was written? And then what is actually written? So will the Supreme Court, it's not a constitutional issue, remember, so will the Supreme Court basically say, well, the intent was such that it didn't matter whether it's federal or state, or are we going to go by what's actually written? I don't have the crystal ball for that. And this is something I don't know more than anybody else. I've studied it a lot, but my gut is that the plaintiffs will not be able to sufficiently convince the Supreme Court members that it was not the intent that everybody who met the criteria is to be covered, and therefore there will be a affirmation essentially of the status quo. The question is, if not, how will it affect you? And it would have a big effect because there are 8 million people out there, that's a rough estimate, but most people kind of agree with it, there are 11 million, go back, the exchanges themselves, of all the people who signed up in the exchanges, only 50% did not have insurance before. And so you come up with this about 8 million figure of people who are getting a subsidy who probably would go uninsured, who would just give up insurance. So how would you deal with it? The Congress would not, because the Congress basically doesn't like Obamacare very much, the House or the Senate, or the majority of the American people aren't going to give any leeway. They could pass legislation and simply say, let's change those 3 words. That's very, very unlikely. So what would likely happen if the plaintiffs win the argument and the ruling is such is that the states would set up risk pools. It would be facilitated in some way by legislation out of Washington, D.C. to at least address most of those 8 million people. There would probably be a delay that, well, those 8 million people, you're not going to throw them out, take their insurance away next year. They might even be grandfathered in, but there would be a transition period. So my crystal ball basically says, and it's a guess, and the former majority leader long before me, but also in Tennessee, and Howard Baker said, if you're willing to look into that crystal ball, always be ready to eat crushed glass. And so I may be eating crushed glass as we go forward with that. The whole value equation of going from fee-for-service to value-based does mean that you have to look at the overall equation, and you do have to look at the cost issue, the dollars that are actually put in. If we look at the cost itself and we look at the affordability itself, and we said that the Obamacare basically said, let's get as many people access to insurance as possible, we still need to come back and address that underlying cost issue. Because otherwise, as overall healthcare costs continue to go up, say, right now they're flattening off at about 4%. They used to be 5 years ago at about 9% a year. But generally over the last 40 years, healthcare costs have gone up 2% faster than inflation. In all likelihood, we will return back to that at some point in time. And therefore, as healthcare costs go up, the whole affordability for the individual and the family and the person who's actually paying the out-of-pocket expenses with higher and higher deductibles becomes a huge issue once again. The move, and I'm sure you talked about the last few days, of Secretary Burwell is really quite remarkable, I think. This whole 30% of Medicare payments to the outcomes via what are now known, and we'll talk a little bit about that, the alternative payment methods. And they could be alternative payment methods. It could be bundled payments. It could be ACOs, accountable care organizations, and 85% of payments to hospital value-based purchasing and the hospital readmission reductions program by the end of 2016, with the increase that, again, I'm sure you talked about, to 50% and 90% respectively by the end of 2018. Secretary Burwell also announced, which I think quite importantly, the creation of the Healthcare Payment Learning and Action Network, which is where the answers are going to be in the public-private partnership, working hand in hand to expand the alternative payment models, into injecting them into Medicare. And this is a historic move for HHS. It's never been done before. The whole idea of setting actual percentage goals like this for a program. And that gives me a lot of hope as well. I'm a person of government and have been active in government for very 12 years. And I'm very much a person of the private sector. Medicare is going to always be the sort of elephant in the room. Everybody's going to look at what Medicare does. And to see Medicare focusing specifically on values, specifically on quality, means that the rest of the world will pay attention. Now, as I'll talk a little bit about in a second, the private sector in many ways, and many of you are straight from the private sector, are much further ahead than where government is. But to have this sort of slow, cumbersome Medicare becoming more nimble, and it being the elephant in the room with everybody looking at it, to me, leaves me very, very optimistic that we're going to see an acceleration in the quality movement from what we've seen in the last year or the last 2 years. What do these APMs, these alternative payment mechanisms and models look like? The APMs that work, meaning the models that we really should choose, are ones that will reduce the cost of healthcare in that denominator part of the equation, while also improving quality. Will actually move the denominator as well as the numerator. That means they will need to not only restructure what they're paying for, but also directly change the way we deliver that medical care, the model, not a one-size-fits-all. And again, the private sector, with its dynamism, with its organic ability to change much quicker than government, will be leading on a lot of these solutions. This move to value-based care is driving innovation and innovative, or what are increasingly known by Clayton Christensen and others at Harvard as disruptive models, which again leave me quite optimistic. The alternative payment models out there, leaving this one-size-fits-all, coming to value-based, include things, as I mentioned, like accountable care organizations and bundling and these global risk measures and capitation measures, the patient-centered homes of a sort, and the issues like palliative health care, which I'll come back to shortly. All of a sudden, we've moved from the quality to the affordability and to the denominator of cost. Let me just take three of the cost drivers out there. Number one, waste. Our fee-for-service model, all of us know, we always quote this 30% figure of waste, of inefficiency, of lack of matching true cost to spending, to inputs, to outputs. Right now, that is about $192 billion a year. And as all of you know, in Medicare, just as comparison, we spend about $550 billion. The number two issue that gives me a kind of optimism, because now with the information technology we can target, is the fact that 5% of the population here, or say 2 tables here, or 3 tables here, account for 50% of all the cost in healthcare. So if you can focus on 3 tables here, you can identify them, which you can today, you couldn't 3 years ago, of who these cost drivers might be. You can focus care on them, and that'll take care of 50% of all the cost in healthcare today if you can target them and wrap care around them, something we simply couldn't do before. And the third is the lack of transparency today. If you're going to empower the markets, which traditionally have not worked in healthcare, why not? Because a doctor has more information than the patient, and therefore if you're having a negotiation, or you have an insurance company over here trying to manage risk and sometimes getting, 20-30% of the take, that doesn't work. The market doesn't work. But all of a sudden, if there's equality of information where you as a consumer are all of a sudden empowered, yes, in a primitive way, but you're empowered with information of quality measures, of being able to choose and being able to walk with your feet, and then you're dealing with the hospital or the provider, markets can begin to work. You, the consumer, the patient, the family, begins to drive my behavior as a doctor, as a hospital, as a provider, where it didn't 5 years ago because of this inequality of information and this fee-for-service system. This lack of transparency means that pricing out there and purchasing is chaotic, it is obscure. It's like Uwe Reinhardt, who is my professor at Princeton, now still a great friend, and all of you have heard him speak all the time, but he said it's like going blindfolded into a shopping center with the purpose of buying a purple sweater. It's kind of what healthcare is today, but no longer as the metrics and the analytics and what quality and what outcomes are all about. Example of models to sort of integrate into these alternative payment mechanisms. First of all, let's take the first cost driver that I mentioned, waste in high utilizers and aging population. There's a company based in Nashville, Tennessee, where I am, that looks at the post-acute space. We know that post-acute space where Medicare has already moved, where there'll be continued movement and where you've had huge success in limiting the number of readmissions by having a more seamless and streamlined care model. And right now, 40% of Medicare beneficiaries require this type of care, so we're talking about a big chunk that we can focus on, and a company like Navi Health does just that. This whole post-acute space is ripe for intervention on a broad scale, and if we can continue to focus on that with the public and private sector, we can have a huge, huge impact. The Navi Health basically contracts with health plans directly to provide this service. Their goal is to save the ultimate payer money by streamlining the course, identifying high quality, channeling patients to high quality, high value outlets. It might be a rehab center, it might be a chiropractor, it might be a doctor, it might be a holistic wellness place, but their purpose is to evaluate in the community the most efficient, most effective, highest quality, highest value place for a particular patient. They can do that today because they can personally go interview the patient while they're in the hospital, on admission, and while they're discharged, and using big data and using analytics, they can predict on admission and then again at discharge what the most appropriate care is, something that simply couldn't be done before. They engage the patients directly in the inpatient setting, provide almost a concierge-like type navigation service to that patient, and they use these very sophisticated algorithms that they have developed that compare comorbidities and other factors to develop a precision type plan or an individualized plan for that patient. Their algorithms predict the very best post-acute setting. They look at readmission risk and get a formula to it. They can look at expected improvement over what time, and they use the quality metrics, which all of you are right in the midst of developing and have developed in the past. Currently, commercial health plans are the people they contract with, but certainly accountable care organizations and patient-centered homes could do just as well. If we look at the waste and high utilizers that are out there today, the sort of 5% of people who are driving 50% of the charges overall, it brings me to a second example, and that is this whole world of palliative health care. Now, when I say palliative health care, I'm going to very quickly jump to the quality and the cost, but palliative health care to me and to you means something quite different. It means taking that last year of life for somebody with chronic disease, not for everybody, but people who have chronic disease, who right now do not die how they want to die, who end up dying in a hospital, in an intensive care unit with IVs in when they want to die at home, the way we want to die. That group of people, it might be a woman, Alma, who's in and out of the hospital 4 different times, who in the middle of the night, because she doesn't have a caregiver or doesn't have a family, when something bad happens, has nobody to call but the hospital. Once you hit the hospital door, you're there, you're admitted, you're there for 3 or 4 days. You might go to rehab after you get home health care, a $20,000 admission that's really totally unnecessary if you took one of the 3 tables here and you identified that patient early on, which you can do again with algorithms and analytics. You identified them and you wrapped a team around them, treating not just their physical health, but treating their emotional health, treating their spiritual health, treating their mental health at the same time you're treating the typical physical health that we do today, and wrap a team of palliative care physicians and nurses and ancillary personnel around them. You improve their care, and in fact, for cancer, they live longer because they're not unnecessarily put into excessive clinical trials. They live a more happy life, a more satisfying life, and a life that is free of pain and suffering. The palliative care model is a model that has been developed. It's been developed in large part by people like the Robert Wood Johnson Foundation and many others about 15 years ago. It's applied in the acute care setting frequently now. Just about every hospital has palliative care specialists available, but it's only beginning to be applied in the outpatient arena. And indeed, the private sector steps up to do that. There is a company that I'm on the board of called Aspire, ASPIRE, which is the largest, right now it's the largest, a very young company that sets out to wrap a team around the individual patients who are identified. So they would go to a company, say an Aetna or say a Humana, and say, let me look at the 50,000 patients that you are covering, and using sophisticated algorithms, they can predict who would need that sort of intensive care for that last year of life, and then not provide that service for everybody who needs it, but just the people who you can identify can benefit from that. And again, a happier patient, a more fulfilled patient, a patient who lives longer over time, with a team of people that are focused on not just the patient, but the family themselves. It's not hospice, palliative care. Hospice care, you've stopped aggressive treatment. It's at that very end of life, but the palliative care model is one that's built around the last year of life, or last 2 or 3 years of life, where you're still aggressively treating. At the same time, you're giving a more emotional, spiritual, holistic type of health care. The last example I'll give, because it comes to the third cost driver, in these payment models, whether it's bundle care or episodic reimbursement, does need to take into account all three of these drivers, or as many as possible, to be successful over time, is a whole field of transparency and the variation in pricing. Right now, if you get a colonoscopy, your colonoscopy will vary anywhere from $900, $800 up to $4,000 in a place like Nashville, Tennessee, or San Francisco, or Cincinnati, even though the colonoscopy is probably done by the same individual, maybe not at the same facility or the same setting, but the question is why? Because the care that the patient gets in terms of the quality is about the same. Once that transparency is injected into the system, smart consumers, not everybody has to be a smart consumer. In a room of 400 people, if you had 10 smart consumers, they can drive the system itself. The best example I can think of today in terms of transparency that can have a disruptive change is a company, again, that I'm on the board of called Theranos. Theranos is a West Coast company that was started by Elizabeth Holmes. Elizabeth Holmes was 17 years of age when she dropped out of Stanford. She was not a doctor, didn't have a particular interest in medicine, but she didn't like to have her blood drawn. And she wondered why when you go to the hospital, they put a needle in your arm, and they get 4 tubes, a yellow top, a red top, a purple top of blood, and makes you faint. She didn't like needles. They take it and put it in a box. They run a few in the lab there. Then they might send it by FedEx up to New Jersey to run in a big lab, and they bring it back. You never see your results. There's about a 30% error rate. It accounts for about 2.5% of all the healthcare spend. And at the end of the day, you may or may not see those results. So she said, why don't we go outside of healthcare? Why don't we go outside of the healthcare arena and go hire 400 engineers, this many engineers from the smartest engineering schools in America, and say, I don't like the fact that you need so much blood for these tests, number one. I want to do it on a drop of blood or a few drops of blood. And number two, I'd like the results within several hours coming back to my iPhone instead of 2 weeks later and me never seeing it. And number three, I want the error rate to go from 30% down to less than 5% of all errors. And number four, I'd like to do it for a fraction of the cost today. 17 years old, had this dream and this vision, dropped out of Stanford and worked on it for about 9 years, did raise enough private capital in Silicon Valley, but people who believed in that dream, including the Dean of Engineering at Stanford, who also left to join her when she was 17 years of age. And now that company is called Theranos. The disruptive component of that from an access is because if you go to Arizona now, in Walgreens, and there are 8,000 Walgreens stores out there, in your neighborhood you can actually go in. You don't have to have a trained phlebotomist. It takes about 6 minutes. You can do all 1,200 Medicare-approved laboratory tests, and you can get your results back within hours to your app on your telephone. It's disruptive in that if the healthcare spend is say 2.3, just say $3 trillion today, laboratory spend is only about 2.5% of that. But if you improve the system in terms of access, in terms of financing, in terms of delivery, in a disruptive way, and the access is greatly improved across because of the cost issue goes down, it affects about 8 out of 10 medical decisions. So the idea of a 17-year-old who goes outside the system, engages in disruptive change, indeed can revolutionize healthcare as we know it today. It takes quality measurements. It takes that reproducibility. It takes cutting that error rate to 1/6 of what it was in the past. And you can only do that by measurement, by analytics, by measurement in such a way that you can compare to others and you satisfy the consumer in a direct way. Let me just close by saying this move from fee-for-service to value-based healthcare is more than words. It requires quality outcomes. It means that the lower cost of medical care has to be a part of the equation in order to make the model sustainable. The only way to do this is to address quality, to address the full value equation, is to address quality in the measurement as well as addressing the drivers of cost. And information technology and the advances that are a part of our everyday life make it possible today. Successful alternative payment models, and they can be the ACOs or the bundled payment or the capitated models, will have to integrate these innovative type delivery systems like the palliative healthcare or like the disruptive technological advances of a Theranos today that will actually lower the cost of healthcare to achieve the value-driven maximization over time. The examples I've given you are really simple examples of the private sector, again, working hand in hand with the tracks that you lay out by your quality movement, which will accelerate. I'm not sure how much you've talked about, but I can tell you from the outside looking in, your movement will greatly accelerate over the next 12 to 24 months. So my final words are that we do have to change the way we're delivering care. The delivery sector has to become a delivery system. And it begins by focusing on those cost drivers coupled with quality. The models that we've discussed today offer reduced and much, much smarter utilization of services via better patient management as well as increased transparency. The beauty of these examples is that the mechanisms are not new, but it's a reconfiguration of past mechanisms that have been used of reducing costs, and they're the exact same mechanisms that increases value and outcomes. My final words to you are the words that I open with today. In my mind, based on my experiences in the political world, in the finance world, in the delivery world, in the affordability world, there's no more important central organizing principle or concept than the movement of quality, a movement of which you are all a part. Thank you very much, and have a great, great rest of the conference. Thank you.